Morning, General, sirs, ma'am. So I'm assuming Major Cheong from Singapore. It's actually the Republic of Singapore Air Force. We are a republic when independent in 1965, so the R stands for Republic. But I stand between your break, so I'm going to make this fast. It's a simple topic, so I'll just dive right into it. So today I'm going to talk about this topic, which is essentially the management of motion sickness in our air crew who deploy on naval platforms. So it's a little bit different. It's not about applicants or air crew who get air sick, but it's really about air crew who are accustomed to their own motion stimuli in their environment, and then we put them in a different operating environment. They develop motion sickness, and how do we deal to mitigate that and ensure that they can still fly? Next slide, please. So this is actually the question. But so I think this one, just to think about it, but really there's two statements is for you to think about. One is motion sickness an abnormal body response, and two, if you find that your aircrew are susceptible, they shouldn't fly. So this is just for you to think about. Next slide, please. So this is my scope. I'll talk a little bit on the physiology, touch on again the operational significance, and then our own operational problems that we face in our Air Force, our approach to the problem, and basically we did an operational study of the relief band and future advances. Next slide, please. So I think this is nothing new. I think all of us know that we are 1G creatures. We live on the surface of the earth. So when you put us up on a 3-axis motion kind of environment, we are not used to our senses. Our sense organs are not accustomed to receiving such stimuli, and there are conflicts, and therefore we generate conflicting senses that give rise to motion sickness. And really, it's a dysynchrony that leads to positive symptoms. So if you vomit, like the first time when I went on the F-16, the pilots tried to do that to you. Yeah. And there's a lot of interplay because it's not just the motion stimuli, but it's really how susceptible the patient is or the person is. And also at that time, what are they doing? Are they just watching the outside world? Are they looking into the cockpit trying to get something done? Are they thinking about the mission? Are they trying to go for the boogie? And what is the environment they are operating in? Is it VFR, or is it instrumental flight rules? Is it or visual? All right, next slide, please. So I think this model is also very well subscribed to. I think all of you understand the Neuro mismatch model in motion sickness. Essentially, you have either a passive movement like standing on a ship, or if I do active motion in the aircraft, such as I pull it to a bank, or I turn my head down to get something in the cockpit, then there's a stimuli that both my eyes, my vestibular organs, as well as my otoliths, some people argue as well as your proprioceptions, they give rise to a combination of sensors that are integrated in your cerebellum, and you have yourself inside their internal model which compares, and then depending they generate a mismatch signal, and at the same time there's an integrator that actually interprets this mismatch, and it gives rise to your motion sickness symptoms. And of course, the internal model also actually goes up to your cortical system, so that gives rise to behavioral responses, volitional responses like fatigue, headache, lack of concentration, lapses, and all that. Next slide, please. So the physiology behind that neuro mismatch model is hypothesized as such. You have your retina, your vestibular organs, your proprioceptive organs. The vestibular nuclei is thought will actually receive these signals, and some will argue that there is also a vestibular ocular pathway as well, and this is integrated at the vestibular cerebellum, and it goes to your various parts of your brain which are responsible for the various responses. I won't go into that. I think we all know that. Next slide, please. So what are the aeromedical concerns? One is you could divide it into physiological and psychological. So really physiological is decreased G tolerance, you have increased heart rate, you have hyperventilation. Those are not good for your AGSM or actually for G tolerance per se. And in the same vein, it will impair your thermal regulation as well. And of course, if you start vomiting, that's physical incapacitation. We're actually trying to fly the aircraft, or the gastric awareness, or the headache, the visual blurring, and those are actually actual, objective physical symptoms that will actually incapacitate your ability to fly the aircraft. And of course, there's psychological, distraction, distress, and basically, subsequently, you might have loss of confidence, right? And there's also this syndrome that's been described, the SOPITE syndrome, whereby they actually have cognitive impairment. Next slide, please. Next. Thanks. So for air sickness per se, I think, as with most Air Force, is really more common in your trainees when they start flying, when they go in to do their circuits, and when they do their aerobats, or when they're going solo. And sometimes they don't want to tell their instructors for fear of being, for being feared that you may disadvantage their selection. But at the same time, the instructors may then mistake that for actually poor performance. And it's usually uncommon in operation air crew. So if you've actually been flying and you're not motion sick, it's really uncommon that you should suddenly develop motion sickness unless you have laid off flying for a while, like you've been posted elsewhere and then you come back, you haven't flown for half a year and you suddenly start flying and you fly a very challenging mission, like 1v1 and all that. Then that might actually reproduce some of that symptoms, but usually they get past it quickly. But if you persistently have motion sickness in the air crew, which has been accustomed, then you need to think about pathological causes. All right, next slide. So for seasickness, actually seasickness is a more prevalent condition. If you look at most literature, is really because of the motion stimuli, the slow heaving frequency and the acceleration associated with seasickness. It's almost 100% that everybody will get seasickness at some point in time. And maybe the naval colleagues will also agree that if you go to sea state 5, it's almost 90%. And there was a RAF. I recall there was a RAF study that showed they did was it RAF or was it Royal Navy? They did a study on their air crew, or basically just on all their naval crew, and found that at sea state 5 it was like up to 70%, but at sea state 1 it was like less than 10%, but they're usually temporary. The symptoms are more dramatic, and that's really because of someone did a study and they correlated the incidence of the motion sickness, the frequency, and the frequency of the heave and the acceleration, and found that at 0.2 and 0.2 frequency hertz heave and 0.1 acceleration, that was the most nasogenic. And that's almost like your ship movement. And the problem with motion stimuli is that if you're adapted to one, doesn't mean you will naturally be adapted to all. So if you're car sick, doesn't mean you'll be air sick. And if you're not sick at all prior to embarking on a flying career, it's not uncommon that you suddenly develop air sickness and so on and so forth. So that's why that's also one of the difficulties and challenges we face in trying to habituate our applicants or trainees who actually develop air sickness. We ground them, we put them in the Barani chair, put them into the turntable, and we turn them till they reach maximal level and say, okay, you should be good to go. But even then, we had people who still go back to the flying environment. They still get motion sick because the stimuli is really different. All right, next slide. So for us, we did my Defense Medical Environmental Research Lab. It's one of our defense-related agencies. They did a study in 2006, and they found that actually 21% of our aircrew actually have some form of motion sickness when they are on the ship. All right, and it's usually worse in the initial days, which is expected. So 95% in the first 2 days, and subsequently almost 100% will get past within the first in the next couple of days, and by 1 week out at sea, they're actually all fine. I mean, barring any changes in the sea state. But of course, if there's an operation need for them to be able to fly at the point of being deployed out at that point in time, then we will need to think of some ways to mitigate the symptoms or to prevent the symptoms from coming on. Next slide, please. Next, yeah, thanks. So this is where I'll share our approach and how we manage our aircrew, our naval platforms. So basically it's simple: prevention and treatment. And really for prevention, we are using the stimulation of your P6 Neiguan, they call it, the Chinese will call it Neiguan, which is your P6 acupoint. which is, anatomically is, your median nerve. And of course, when that is not good enough and you still get symptoms, or if you didn't use this and you get symptoms anyway, and it's bad enough to impair you, then we'll need to institute some form of treatment, which is usually pharmacotherapy. And for us, we use a combination of anticholinergics as well as adrenergics. And it usually will entail some form of flying restriction while they are on that medication for the period of time where the drug is thought to be pharmacologically active. And once that drug washes off and the guy is good to go, then he's unrestricted. Next slide, please. So for us, our standardized therapy is oral or IM promethazine, 25 mg twice a day maximum. We choose promethazine because based on our pharmaco studies, it actually has very little anticholinergic actions, but it's a H1 specific antihistamine. So it's thought to act on the vestibular pathway and also some central acting pathway, but at the same time some dopaminergic effects. But if you look at the side effect profiles, it actually has very good, I think one of the most favorable side effect profiles compared to your other medications that you use for motion sickness, like your cinnarizine, your prochlorperazine, and your metoclopramide, because those drugs they have more actions, they are non-specific, and they tend to have a bit more of your anticholinergic response, such as your gastric symptoms, nausea, vomiting, fatigue, tiredness. So promethazine actually has a very good profile in terms of that. And at the same time, it is also short acting, so 4 hours in maximum. Fast rate of onset about 30 minutes. So so we use this. I understand that the US Navy actually used amphetamines as the counter, as adrenergic, but in Singapore it's not approved medications, but we use pseudoephedrine, 60 milligrams together with this. So how do we do this with their crew rascals? Obviously, if you give them promethazine, they will be tired, or they maybe no effect, hopefully. But if they are supposed to fly, then only about 12 hours later, or maybe 6 hours later, they have some rest in between. If you were to give them promethazine now together with pseudoephedrine, then they may not be able to fall asleep. So for as far as we are concerned, it's simple. If you are given promethazine, you are straight away with co-pilot for 12 hours, but in that 12 hours, if you need to fly anytime, usually it's pre-planned, we will give you pseudoephedrine 1 hour before your flight. So that should kick in just right at that time. Alright. If you use any other medications, it's 24 hours, so basically no fly, just go to your bunk, rest, and hopefully you get past that motion sickness symptoms. Next slide. So, talking about the relief band, there's a disclaimer, it's a little bit late, but we have no financial links to this company, but you'll be surprised if you look at the relief band, which is, I think the company is Aero Medical RX. I think it's the only FAA approved relief band, and for that reason we chose that particular brand to trial it on our air crew, not because it's better or anything. So it's been shown in many studies that there might be some effect for antiemetic post-laparoscopic surgery, as well as post-chemotherapy, and as well independent study that was published in ESMA showing that there has some positive effect, compared to placebo. Whereas there were also studies that showed that it wasn't useful. But I think the key takeaway here that we felt that why we wanted to use this was that if it didn't make you feel better, it definitely didn't make you feel worse. I mean, the tingling sensation you feel from the acute stimulation, you are not they're supposed to turn it off when they fly, so technically that's not supposed to give them problems. And it's also voluntary, we don't force them to use it. So the thing is that if it will make you better, then it's good. But if not, it doesn't make you worse. So I think from that point of view, we think that it is a useful adjunct in terms of preventing motion sickness. Next slide. So for this study we did a couple of years ago, we had a total of 44 subjects, and then 21 were on using the relief band prior to deploying onto the ship. And then we had 23 people who just basically did use nothing. And we score them daily using a symptom-based motion sickness score. And it's a score of scale 1 to 7, so once you're more than 4, you're considered sick. Next slide, please. So this is show you the one that we chose. the band that we use, right? So it's taught to, by putting it right, so you're supposed to put it right about 1/6 the distance between your crease, your wrist crease as well as your cubital fossa. So that's just where your median nerve is, and you landmark it basically 2-finger from that crease, and then you try to position it right between your two, your radialis carpi, flexor radialis carpi, as well as your palmaris longus, and that's where the stimulation should be felt. So that's where the median nerve is, and essentially the action behind that is taught to by doing that, is taught to disrupt the gastro pathway of the motion sickness pathway. So it's supposed to disrupt any gastric, the gastric neurological, gastric cortical pathway, and by so doing that, you arrest the onset of symptoms, or you reduce the severity of the symptoms. Next. So what we do is that we went to the squadron, we briefed them, and then we went through them the score. So basically, if you look at here, there's basically most of the symptoms that these are the common symptoms that are associated with motion sickness, but those in bold are major symptoms. Those not in bold but normal characters are minor symptoms, and then those in italics are others. So, well, of course, we don't annotate that in the score in the survey we give them, so they don't know. So they'll just score it accordingly, and then we'll take it every day, and then we will then determine what was their motion sickness score. All right, next slide, please. So this is the grading criteria used. So basically, if you are 4, means you have one major, and one minor, or you have 2 minor, then you're or beyond, then you're considered motion sick. Okay. All right. Next slide. Thanks. So what we found in our study was that there was a lower average treatment score in terms of the scoring for those who were on the relief band and versus those who didn't. I mean, if you look at the maximum score, it's about 2.53 for those who are using a band versus 2.87. So about a 5% decrease, and you can show elegantly in the graph. So the day one, none of them had symptoms, a few of them had, and then following day, most people started to have symptoms on the second day, and third day, and then by the 5th day, 6th day, most people get better. So usually within a week, everyone gets well. But I think what is also good to point out in this slide is that if you look at those people who are on relief band versus those people who are not, the progression and the prevalence, how the incidence of motion sickness appeared similar. So in that sense, we sort of derived that the relief band didn't actually affect the person's natural ability, or the cohort's natural ability to actually overcome motion sickness. So in that sense, and also relief band issue works on a peripheral pathway rather than a central pathway, like your medication. So in that sense, it is something that's positive, because you don't interfere with the body's natural adaptive system, but in a way you just accelerate or you reduce the severity of the body's natural response. Next slide. So then again, we look at maximum score. So 49.2 was sick versus 52.3. Not a lot, but it's about half. So 4/10, about 10% decrease, right? And it's prevalent throughout the whole 1 week that we scored them. Next slide. And the last is that looking at the onset, I think just now I already have described that, but really most of them had a later onset, if not no onset. Yeah. So first day there were people, second day there were some, but usually if you look at the trend, most of them had a later onset and actually a faster recovery as well. Next. So, okay, there were some limitations. Obviously, this is done in a small sample size based on one study, and it's operational data. So there are a lot of other factors that we couldn't control, like their work rest, what kind of sorties were they flying, and obviously we can't tell them no go unless the person was really sick. Surprisingly, we didn't have anyone who had to drop out because they were so sick that we had to give medications and they had to be grounded. But still. And the trend in this study suggests that actually acute stimulation does attenuate motion sickness in the unclimatized. And it does delay the onset. It does not affect your natural acclimatization, as you see in the graph that we showed. So we feel that if you don't use pharmacological methods, you keep to natural techniques, actually it may afford better protection, and also it reduces the possible harm that you can actually give to the patient. Next. So conclusion, it is useful, it is an adjunct, right? And it's applicable to aircrew who do not routinely deploy. And well, of course, at the same time, while we have that in place, we will continue to look at new substances or new devices out there which can help us to counter motion sickness or to reduce the symptoms. And I'll go quickly into them. Next slide. So I think screening selection continues to be difficult. I think we've seen the slides by NASA trying to look into parameters for motion sickness. But I think there's a lot of talk and a lot of ways that has been suggested how you can actually screen people. But if you think about it, having a normal vestibular function, then it's expected that you get motion sickness. But of course, screening and selection will be trying to delineate and identify people who are more resilient to unadapted or conflicting motion stimuli. But you study so far using the Barani chair, the autokinetic drum, objective data looking at heart rate variability and salivation rate and all that has been limited in allowing us to actually come up with a good selection system. Yeah. So no single parameter. And it's also operationally difficult to implement. Next slide. In terms of prevention, just like the previous slide, sometimes we can use biofeedback or habituation, like using the Barani chair and all that to spin them. But then again, it's the same problem that is a prolonged downtime, and not necessarily this habituation or neurofeedback that you can give them will definitely allow them to overcome the symptoms. And if you look at if you think about it, it's within the first 7 days, everybody will get better, or most people will get better. Then is it really worth the effort to try and come up with something just to get them past that 2 days? Maybe you should then fly in 2 days earlier, get yourself acclimatized to the ship before you start admissions. That's what we try to do. All right. Okay. So the inability to predict transferability, I think that's a key issue. I think that is across all motion sickness programs that at least in my Air Force, when we try to develop, that's a problems that we face. Next slide. I think treatment are still the mainstay. They're looking at all the pharmacological options out there, right? And most of them are limited, either not fit to fly or restricted because of the non-selective central acting qualities, right? And the adverse effect is still an issue. So there are studies, I think right now everybody, or actually for the last 10 years, if you look at the literature, people are looking at nasal or transdermal scopolamine as a useful treatment for motion sickness. But then there are difficulties in trying to determine what's the correct dose that will also minimize side effects but maximize your pharmacological effect. And with transdermal, it is a long acting, so it's 6 hours to get on set. It takes 72 hours to go away. So if the person develops side effects, you cannot reverse it. And the problem with intranasal scopolamine is that it's too short acting, and also there's been recent literature to say that what are the long-term implications of intranasal scopolamine is also unknown. But I just saw an interesting article that Chinese are actually coming out with an intranasal gel, so that might be able to lengthen the dosing period that you can do. But then again, some of the issues about scopolamine, the central acting qualities, the side effects, and what exactly is the correct dosing, the dosages you want to give to your aircrew, that one still has yet to be delineated. Next slide. So new therapies out there. So some people are looking. Most of the drugs, even for like acute stimulation, it works on the peripheral pathway. It disrupts the gastric and the gastro cortical pathways, or the gastrolimbic or the gastrovascular pathway. But there are people who are looking into medications that actually they use to decrease the nystagmus effect, the nystagmus effect, and Some of them has, like acetylcholine, baclofen, gabapentin has been suggested maybe future drugs that we can look at, but this is very new, and obviously if you look at the drugs, they are used for something else. So what would be the correct dosage to use? How do you minimize side effects? Is it safe to use, despite being useful for motion sickness? That is yet to be seen. And of course, ginger actually has been there for a long time. I think the Australians use it. There are studies to show that the active compound, the zonocoids, are actually useful and with minimal side effects. So this is something that at least I'll be looking in my next couple of years. I mean, well, it's the same thing. If it's a natural product, if it has little side effects, then it's like eating a piece of ginger. If it doesn't make you feel better, it doesn't make you feel worse. And maybe the chewing on the ginger will distract you and maybe you will feel motion sick. So next slide. So in conclusion, seasickness is common for aircrew who do not routinely deploy. I mean, for my guys who are on the naval helicopter, the Seahawks, it's not an issue because they are flying on the frigates or the landing ship tanks, but sometimes my other squadrons who are from the Chinooks or the Super Pumas might need to come in to augment them, and they are not accustomed to the naval platform, so they get issues. So this is really to help aircrew on a whole when they deploy to accustom and overcome the symptoms. And we use a combined approach of prevention and also treatment. And of course, we will continue to look for better pharmacotherapeutics. Next slide. I think that's the last slide. Yeah, so I personally think that it is not an abnormal response. It's actually a normal physiological response. The only way to make yourself immune to motion sickness is to have a vestibulectomy. Yeah, so, yeah. And I definitely agree that we can still fly them, but we need to mitigate the symptoms. We need to determine what is the aromatic, the safe to fly, and what is the envelope that we want to push in terms of allowing that fitness to fly while they are still having symptoms. I think that's all I have. Any questions? No? Thank you.
Thank you.